gained so much from so many. Some amazing people in my life who have cared with boundless love. Eternally grateful I am to them. I'm also thankful to the teachers who have given without holding back. So, can I give something back? I certainly hope so. Hopefully, this will be helpful to some young physicians in their clinical journey and in their exam preparations. That for me would be amazing. Hello everyone, welcome to today's presentation by a physician's cup of coffee on Serum Osmolar Gap, part 9 of the ABG series. Throughout this series of presentation, this has been the stepwise approach that we have been discussing. Today we would look at step 8, where you do the anion gap, and only if it's an AGMA, then we look at the delta anion gap to delta bicarb ratio. And then if the clinical context is appropriate, we go on to do the serum osmolar gap. And serum osmolar gap is what we would be discussing today. When we already have a serum anion gap, do we really need the serum osmolar gap? Is what we would be discussing in today's presentation. To reach there, we will have to know what is the osmolar gap, why is there an osmolar gap, and of course, why do we need the osmolar gap would lead us to the question when to check for the osmolar gap. Let's look at those issues. As shown in the previous slide, the serum osmolar gap is the difference between measured serum osmolarity and the calculated serum osmolarity. The ideal methodology to measure the serum osmolarity is by the freezing point methodology. That's something to be kept in mind. The measured osmolarity takes into account all the osmotically active molecules, including ammonia and its excretion products, and osmotically active proteins and lipids and everything else. Whereas when we calculate the osmolarity, the ammonia, its excretion products, and certain proteins and lipids are not included in the calculation. Thus, you have a difference between the measured and the calculated osmolarity. That's why we do have a serum osmolar gap in physiology. The range in physiology is 10. Anything above 10 is a raised serum osmolar gap, and when it reaches around 20, it's very concerning. What should we worry about? I'll come to that in a moment. This was a slide presented while discussing the serum anion gap. The same causes of high anion gap hold true for a high osmolar gap as well. Thus, we could make use of that knowledge here. When we discuss high anion gap, I divided them into 5 physiological processes that have become pathological and 5 exogenous causes. The 5 physiological processes that have become abnormal were the ketones producing pathology of diabetic ketosis, alcoholic ketosis, starvation ketosis, and then we had lactic acidosis and renal failure related uremic acidosis. Though urea is not the component that was leading on to acidosis, we have discussed that in the high anion gap presentation. In the non-physiological processes, the exogenous components were, for the high anion gap, I discussed 5 causes of exogenous toxins that were causing high anion gap. The same 5 causes could be contributing to the osmolar gap as well, except that paracetamol does not contribute to a osmolar gap. Instead of paracetamol, I would add isopropanol intoxication. So the 5 exogenous causes would be isopropanol intoxication, toluene, ethylene glycol, methanol, and propylene alcohol. These 5 exogenous toxins or alcohol would be contributing to a high osmolar gap as well as a high anion gap, except for isopropanol intoxication, which I would discuss in detail. There is something specific related to the isopropanol intoxication which we should be aware as physicians. Now we do know that high anion gap metabolic acidosis causes are the ones that lead on to a high osmolar gap as well. But we do have to remember that it is not the sodium bicarbonate or the chloride ions that lead to the high osmolar gap. There are additional products like toxic alcohols, acetone or glycerol that contribute to the osmolar gap. Also do remember that acetone is not an acid and does not contribute to the anion gap but does contribute to the osmolar gap. So if acetone doesn't contribute to the anion gap, what causes the high anion gap in a diabetic ketoacidosis? Which of course we would look in a few minutes. We looked at these toxic alcohols 2 slides ago, and when we are presented with a high osmolar gap, these toxic alcohols are of significant concern. Now that brings us to the all-important question of when do we do the osmolar gap and what information can the osmolar gap give us and how do we make use of the osmolar gap. Do we need to do an osmolar gap for every patient? Absolutely not. Doing every test for every patient is not scientific medicine. We've got a patient who is unwell, you've done an ABG, you identified a metabolic acidosis which is a HAGMA, and if you got the cause clear and you're sure about the etiology of the HAGMA, then you don't need to proceed to do a osmolar gap. However, you've got a patient who is unwell, you identified a HAGMA and your cause is unclear, please proceed to do a osmolar gap. Similarly, you got a patient who's unwell, drowsy, and you don't know the cause, you suspect there could be a toxic etiology, then do a osmolar gap. And then whether the patient's got a metabolic acidosis or not, whether the patient's got an anion gap or not, whether that's HAGMA or not, if you suspect a toxic alcohol being involved in this patient's low GCS or drowsiness, please proceed to do an osmolar gap. A physician who suspected this situation and gone on to do an osmolar gap has diligently worked up this patient. Whether he identified something on the osmolar gap or not, the physician has worked up this patient reasonably adequately. That's my point. In the previous slide, I did mention when you suspect a patient to have ingested a toxic alcoholic product, whatever the GCS may be, whether they are drowsy or not, whether the electrolytes are normal or not, whether there is an anion gap or not, even whether there is a metabolic acidosis or not, anion gap or not, HAGMA or not, NAGMA or not, if you suspect a toxic alcohol ingestion, irrespective of your lab profile, you would go on to do a osmotic gap assessment. If you've done that, you have diligently worked up this patient. And why do you need to do that osmolar gap in such a situation? That is because the toxicological profile of the 5 exogenous toxins that we spoke about, isopropanol, toluene, ethylene glycol, methanol and propylene alcohol, the way they behave, the way their metabolic products present in the body, and their time profile in the way they present in the body makes it imperative that we need to do an osmolar gap to identify their presence. I would discuss that in detail in the coming slides. The initial presentation of these toxic alcohols can be a raised osmolar gap with a normal anion gap, and as metabolism proceeds it could change into a high anion gap metabolic acidosis with the osmolar gap disappearing. Thus, in the initial stages, osmolar gap might be the only clue that we could identify these toxins present in the body. We would discuss them one by one individually in the coming slides. Before going on to discuss about individual toxic alcohols, two things I would like to point out from this slide. One is that propylene glycol could be a component of intravenous seizure medications. Two is there are non-alcoholic causes of high osmolar gap, namely mannitol, sorbitol, and the thing to remember is glycine through the TURP procedure. Glycine being used as part of TURP procedure can also lead to a high osmolar gap. Low molecular weight contrast being used in the context of renal impairment is another source of high osmolar gap. Now let's look into individual toxic alcohols. Isopropanol, which is a component of rubbing alcohol in hospitals or anywhere else for that matter, is being used quite a lot. It, when metabolized, does not produce an acid byproduct. It produces acetone, which does not create a hagma but leads on to a significant osmolar gap and ketosis because it's acetone. So it does not have a hagma, it has a high osmolar gap, and it produces a ketosis. In this context, if you suspect isopropanol intoxication, doing a hagma would not lead us to the diagnosis. Thus, we need a osmolar gap assessment and checking the urine for ketosis. Similar to isopropyl alcohol, too much of ethanol leads to intoxication, and this too leads to an osmolar gap but does not have a metabolic acidosis. So we've looked into two toxic situations where if you do an anion gap and look for a hagma, you might not have a hagma, but it is only an osmolar gap that would lead you to the diagnosis. While with isopropyl alcohol and ethanol, we would not have a anion gap or a hagma at any situation. We have only a osmolar gap. Whereas with methanol and ethylene glycol, the situation is a bit different. Here, initially they present as high osmolar gaps, but as metabolic products accumulate and organic acids are formed, the osmolar gap gets converted into a hagma. So they too initially only will present with a osmolar gap, which later becomes a hagma. Whereas with ethanol and isopropyl alcohol, we don't have a hagma at any stage. They are only higher osmolar gap producers. with toluene intoxication, the scenario is slightly different. Here, initially, it produces acid byproducts, and thus you have a hagma without a osmolar gap, and later as the acid byproducts are renally cleared, the hagma gets converted into a osmolar gap. This pattern is different to what we discussed with the other 4 toxic alcohols in the previous 2 slides. This is a slide from UpToDate. They have divided the causes of serum osmolar gap into 3 broad categories. In the middle are causes that are physiology that has become abnormal pathology. Among them is uremic or breakdown products from chronic kidney disease. Then you got the diabetic, alcoholic or starvation ketoacidosis and lactic acidosis. On the top, there are the causes that initially present with a high osmolar gap and then can get converted into a hagma. So initially you pick them up only if you do a osmolar gap. Then at the bottom we got the causes that do not present with a hagma at any time in their presentations. So they are mainly ethanol and isopropanol, which I had explained earlier. But keep in mind there is another category of causes which I'll remind in the next slide. Not mentioned in the UpToDate slide are the other non-alcoholic or non-toxic alcoholic causes that result in a high osmolar gap, mainly mannitol, sorbitol and glycine related to the transurethral resection of prostate procedure. And also remember, low osmolar contrast, particularly in a chronic kidney disease situation, results in a high osmolar gap. So remember that not all osmolar gaps are due to toxic alcohol. This is to emphasize that ketoacidosis be due to whatever one of the 3 causes, that is either diabetic, starvation or alcoholic. They do produce ketone bodies, and these ketone bodies produce high anion gap metabolic acidosis and a osmolar gap depending on the time frame that we identify what's happening. Among the ketone bodies is acetone. Acetone is not a chemical or component that leads to the hagma. Acetone leads to the osmolar gap but not to the hagma. So if acetone doesn't lead to the high anion gap, then what does? I asked this question earlier as well. Let's look into it. So ketoacidosis is a deranged metabolic state where the body produces ketone bodies, namely acetone, acetoacetate and beta-hydroxybutyrate. So acetone leads to a high osmolar gap, whereas acetoacetate and beta-hydroxybutyrate contribute to the hagma. And to emphasize again, acetone does not contribute to the hagma. So this is to summarize that ketoacidosis is acetoacetate, beta-hydroxybutyrate and acetone, and acetoacetate and beta-hydroxybutyrate contribute to the high anion gap, whereas the acetone contributes to the osmolar gap. And this is to revise that metabolic acidosis is not a feature of isopropanol toxicology at any stage. It produces a high osmolar gap and a ketosis. So the only way that we could identify isopropanol poisoning is if we considered that and went on to do a osmolar gap. A high anion gap will not lead to that diagnosis. Like I mentioned earlier, a physician who has thought about this and gone on to do a osmolar gap has been a diligent person. Before we delve into a clinical problem solving session in the form of an MCQ, let's just revise that if the cause of the hagma is unclear, proceed to do a osmolar gap. If you suspect a toxic alcohol ingestion, consider doing a osmolar gap. Okay. Looking into this particular clinical scenario, patient has been brought to the emergency department intoxicated. Blood sugars have been noted to be on the lower side. So the initial assumption had been alcohol-related intoxication. They have done a blood gas, but my question would have been, a patient who is known to them from previous similar presentations, what prompted them to do a blood gas? Of course, it's good that they did the blood gas in this patient, but my thought process would have been, okay, what would prompt us to do a blood gas in the first place? Okay, that's one. Because we, if a patient with a known alcoholic intoxication history presents to the emergency department and has had similar previous presentations, and if the assessment is alcohol-related intoxication, it's not likely that every emergency department would initially do a blood gas, but it's been done. But that's something that is within the normal range. Over time, he actually deteriorates and has to be taken to the intensive care unit. His second blood gas is significantly bad. It actually shows a significant metabolic acidosis. Now, what do we think is going on with this patient? And is there something else the initial doctor could have done? Of course, he did a blood gas. That's excellent. Now, knowing what we know from previous discussions, is there something else that could have been done? It's not a case of hindsight being 20/20. I'm just trying to discuss from what we have gone through previous slides to see whether we could apply that to a clinical presentation. The initial assessment of the team looking after the patient based on the low blood sugar and his history of alcohol intake, initial assessment was that his presentation was likely secondary to alcoholic ketoacidosis. But keep in mind that is a HAGMA situation, and this patient did not have a high anion gap. I don't think they did have ketones demonstrated either. And also remember, the anion gap was normal. So what else could have been done is the question here. What else? Is there something that could have been done that could have helped us? So looking back at this patient's presentation, initially presented to the ED with alcohol intoxication with a normal looking arterial blood gas and subsequently significantly deteriorated with a high anion gap. In our previous slides and discussions, we have discussed that there are two toxic alcohols that can present this way. Initially, they would have no HAGMA, they would have no anion gap, but if we went on to do a osmolar gap, we could identify a high osmolar gap. So that would have been, osmolar gap is the step that would have probably led us to a diagnosis. So this patient actually had methanol intoxication, which is one of the two toxic alcohols that can present this way. Also interestingly, this patient did have a metabolic acidosis and did not have adequate respiratory compensation. His PCO2 levels were very high, and that was due to the methanol-induced respiratory depression and CO2 retention. So this is a significant clinical situation that we need to be aware of. So if there is anything that we could learn from that presentation, it's that there are intoxicants that can initially present with a normal anion gap, but if we did do a osmolar gap that would be elevated. And as time goes and metabolism proceeds, that osmolar gap disappears and a high anion gap becomes evident. I did mention there is a second toxic alcohol that behaves similarly. Could you recollect what that could be? The second toxic alcohol that behaves this way is ethylene glycol. So methanol and ethylene glycol intoxication can initially present with a raised osmolar gap but a normal anion gap range. But as toxic alcohols get converted to organic acid, they then become a hagma and the osmolar gap disappears. The same patient presents again a month later, intoxicated this time as well. So his initial clinical presentation and his initial blood gases were not dissimilar to his previous presentation. This time though we have learnt our lesson and a serum toxicology was sent and ethanol was measured to be low levels and he did not have methanol. We tested for that because the last time he presented with methanol intoxication. Urinalysis did show ketones but with no blood or protein. Similar to the previous presentation, he deteriorated, became unconscious, had to be intubated and transferred to the intensive care unit. The ABG though this time showed a significant acidosis, but the difference was this was a severe respiratory acidosis. His bicarbonate was actually on the higher side, showing that compensation was taking place. Osmolarity was done and he did have a significant osmolar gap. So what do we think is going on? So as discussed in the previous slide, his initial blood gases were on the normal range and subsequently severe respiratory acidosis and metabolic compensation happening there. Now we got to work out what could be causing this situation. So the clinical clues here are that he's got no acidosis and no acidemia and no hagma. Urine did show ketones and he had a significant osmolar gap and he is suspected to be intoxicated. These are the clues. So we've got a patient who is intoxicated, who is unconscious, intubated. The ABG show an acidemia with a significant respiratory acidosis with no metabolic component. No metabolic acidosis, no hagma, but a respiratory acidosis. And he's got a high osmolar gap with urine showing ketones. We have discussed this toxicology profile previously. This is a typical presentation for isopropanol intoxication. It does not have a metabolic acidosis, so will not reveal a hagma, but it would present with a high osmolar gap and a ketosis. So how do we actually make this diagnosis? The key here is clinical knowledge, and so your clinical intuition leading you to suspect it and then doing an osmolar gap and checking for urine ketones or serum ketones in a patient presenting with intoxication suspected to be an alcohol or toxic alcohol. So it's your clinical knowledge that would lead to this diagnosis. Now moving on to a different toxicology component, toluene through glue sniffing. Does toluene intoxication cause a hagma or nagma? This is actually an interesting debate in literature. There are authors who classified toluene under hagma producing pathology, and there are authors who classify toluene toxicity under nagma. So does toluene cause a nagma or a hagma? Actually, toluene causes both. Toluene intoxication initially generates hippuric acid, which leads on to a hagma. Hippuric acid is rapidly renally cleared. It takes time for ammonium components to form. However, initially it's rapidly cleared renally by combining with sodium and potassium, which are cations. Thus, you have the acid component, hippuric acid, being cleared and cations, sodium and potassium, being lost in the urine along with the hippuric acid. So, you have a situation where the hagma now gets converted into a nagma. Because many a times the diagnosis is delayed, we see the patient with nagma. That is the reason for the confusion. So initially it produces a hagma, which then gets converted into a nagma. The other significant electrolyte abnormality related to toluene toxicity is hypokalemia. And hypokalemia can be severe, and it leads to significant morbidity. There are multiple case reports related to hypokalemia related deaths in toluene intoxicity. The mechanism is losing sodium and potassium leads to a extracellular volume contraction. Thereby you have secondary hyperaldosteronism, where sodium gets reabsorbed in the tubule, and you have potassium and hydrogen ions being lost. This hydrogen ions being lost leads to hypokalemia. That's the mechanism of hypokalemia in toluene toxicity. Because of the hypochloremic nagma and the associated hypokalemia, toluene toxicity was clubbed together as a renal tubular acidosis, distal type 1. However, there are two different entities. Toluene is not a cause of RTA type 1. In toluene toxicity, the kidneys are functioning normally and you will end up having a high urine ammonium concentration. Whereas in distal type 1 RTA, the primary defect is a hydrogen ion secretion defect, and if you measure the urine ammonium level, they would be low. Thus, toluene is not a type 1 RTA. And as far as I am aware, there is no literature indicating that the toluene does cause a high osmolar gap. So toluene causes a hagma, which then gets converted to a nagma. But there is no evidence to say that it does cause a osmolar gap. Similarly, DKA2 initially presents as a hagma and subsequently on volume repletion gets converted to a nagma. DKA2, similar to toluene toxicity, initially presents with the hagma and subsequent to volume repletion with sodium chloride containing fluids gets converted to a nagma. The main physiology behind the conversion from hagma to nagma is the renal excretion, better renal perfusion resulting in renal excretion of the acidic component hydroxybutyrate and acetoacetate. Thereby the acid components get excreted and you have a hyperchloremic nagma that develops, which initially was a hagma. The question has been asked whether you use the corrected or uncorrected sodium for the anion gap or osmolar gap calculation. The answer is the uncorrected, because whatever effect is created by the hyperglycemia is same to every electrolyte. So thus you correct it with you use the uncorrected sodium for calculations. This is a slide depicting the formulas used to correct sodium for hyperglycemia. However, I would like to emphasize that we use the uncorrected sodium for anion gap and osmolar gap assessment. It's the uncorrected sodium that is used. We discussed about high osmolar gap and a normal anion gap situations, or a high osmolar gap, the absence of HAGMA. Is there any situation where you can have a high anion gap with a normal osmolar gap? It's mostly the raised albumin level. That's the situation where you can have a high anion gap, but the osmolar gap would be normal. If there is a situation where the osmolar gap is disproportionately high compared to the ethanol level, then suspect additional toxic alcohol as a contributory factor. Lactic acidosis does contribute to a high osmolar gap. However, the level of lactic acidosis has got to be significantly high to contribute to a osmolar gap. To summarize this presentation, consider doing a osmolar gap in any patient suspected of intoxication, be it with ethanol or toxic alcohol. Consider doing a osmolar gap in any patient where the cause of HAGMA is unclear. Consider doing a osmolar gap in any patient who is intoxicated and drowsy. And consider doing a ketone assessment, either urine or serum, in osmolar gap situation when it's appropriate. So thankful to so many people who have given so much. Did you find this useful? If so, if you liked it, kindly hit the like button and subscribe. Here are some of the topics I plan to discuss in coming days. If you do have any particular topic that you would like to be discussed, kindly let me know. Thank you very much for listening. Have a good day. Let's meet another day with another topic.